So I'm Shomik Sengupta. I'm a urologist from Melbourne and involved heavily with ANZUP. I'm here discussing things with Dr. Bertrand Tombal, who we know very well at ANZUP, and he's a urologist from UCL Brussels and, of course, of EORTC involvement. Welcome to the ANZUP 2022.
Thank you. Pleasure to be here.
We've just come out of a session looking at the future of prostate cancer and heard about a real wide range of advances. What did you think about the use of PSMA PET in the diagnostic space?
I think that's a tendency we have to push everything earlier. And it's important, I believe, to come to the question. The question is, should we biopsy all the Pirates 2 and 3? So that's the question. Then look, what do we have now? I think that what we shouldn't do now is biopsy all the ANZUP 2, ANZUP 3. What we tend to do in Europe is follow the recommendation for reflex testing and integrate that MRI value into a standard algorithm that I got on my iPhone, and based on this you can have a percentage risk of having significant cancer and speak to the patient. And that's a €0 technology if you have your iPhone. So I really believe that the gold standard should be for every new technology to be added on top of that and see how much it improves the accuracy of the algorithm. And we have great example of failure. For instance, you remember 10 years ago there was a PCA3 test that you would do, urine test, very promising also, and then it appears that when it came into the algorithm, additional value was limited. No, there are indications. If you think
so when you're talking about the algorithm, you mean incorporating the clinical risk factors?
Basically, it's the traditional one, whether you had a biopsy before, yes or no, your age. The two most important, the PSA value and the volume of your prostate, because many of these tests, including MRI, have a hard time in front of PSA density. And then the result of the digital rectal examination, and then the MRI on top of that.
And it's a very salient point that we talk often about the individual predictive parameters on MRI, but of course we rarely use MRI as a standalone test. It's in the context of all of that clinical information. And as you say, PSMA needs to build on that, not just exist as an isolated test in the space.
No, and a quick calculation would be that in probably 70% of the men with a PSA less than 10, you wouldn't biopsy Pirates 2.
Yes.
So I think that
it's a selection tool.
It's a selection tool.
Yeah. So once we've diagnosed it, we heard from Dr. Loblower about the evolution of radiation treatment. I guess it's something that you and I don't primarily do, but we deal with patients who are thinking about it. And you asked some questions in the session regarding the current role. Do you have some summating thoughts about where you think radiation fits in this space?
No, to be honest, Belgium is a country which has always been very privileged in terms of access to radiotherapy. We have 2 ml LINAC in Brussels. We have several adaptive machines. We have proton therapy. And honestly, for the patient, when they look at especially sexual complication, patient in their 50, 60, and know that they can be offered radiotherapy with, up to 7-8 cycle of radiotherapy, that's ultra competitive.
Yes.
So if I would be like a urologist marketeer, I would say we lose a lot of market share. And I think the trend will be increasing because like at EAU 2 weeks ago, the European Patient Organization, Europa WOMO, reported the result of their EUPROMS trial, which is very large transversal assessment of quality of life using 2 standardized questionnaires. The results are clear. If you look at 3 to 5 years, sexual activity is much more conserved in patients doing radiotherapy. And as urologists, we often quote the risk of local recurrence. But to be honest, when you look at what Andrew Loblow has been showing, that's extremely low. So as urologists, we have to be prepared in the next 10 years to really rethink what's going to be the remaining role of surgery.
Yes.
We can't no longer sit on the fact that we are better.
Yes.
No. We're kind of surrounded by a whole world of data, and really we're going to have to do, because the niche is, really getting narrow.
We heard yesterday it's still underused in Australia, but that may change in the next 10 years.
But actually, it's about patient information. That was yesterday. I attended that great session on patient information. We must say that many of us, we lack equipoise in presenting
That's the problem. Yes.
to the patient. But if you start by telling, okay, you can get radiation because surgery is better, patient will go for surgery. But I think we are not allowed to say that, because either we don't have proper data, or the data we have don't indicate a major difference. So we have to be extra careful. We have to inform the patient, and we have to accept the fact that they may not choose surgery, which for us,
we have to collect more data. That's
for us surgeon, that's difficult.
That's difficult. And then finally, we heard a slew of talks about the increasing range of systemic therapy options. There's the lutetium. There are all of the movements beyond androgen deprivation. It's too big a topic to really discuss in the time that we have, but certainly the future for prostate cancer looks very bright. Was there anything you drew out of those three talks that you want to just share with
Yeah, that clearly, having been president of EORTC, I had a look on, lung, colon, and all these cancer. We're still not very rich. We still have a limited number, because if you think about APA, DARO, ANZUP, ABI, basically that's one bucket.
Yes.
Then we've got PSMA lutetium, we've got cabazitaxel, and then we've got the PARP inhibitor world. So it's still, so in the end, I like the therapy trial, because that's a really pragmatic trial, because these are the two options left in many of the patients, because they don't have any DDR mutation detectable. They have been receiving hormone. So that trial that some quote quote small actually is the best piece of evidence we have today.
Correct.
I might not be absolutely 100% fully in agreement with Michael about how beautiful it is, but I think it's very informative. And to me, what's the most informative is that in the end, it's not about lutetium or cabazitaxel. It's about managing to be able to give both to everybody. And then it comes to the sequence. So you start with CABA, you start with PSMA lutetium. That's very interesting. But we should stop seeing these trials as a contest between two opponents.
We are too often
I'm big, you're small, I'm better. No. I mean, for the patient, we have two very effective drugs. One is still kind of a precision medicine drug, and that's the beauty of the therapy, is that there's been a lot of work in selecting the patient. But so we may help patients with that, but we should build more trials like that, because when I speak to patients, I never use the vision trial anymore. I mean, vision is there for my payers.
Comparator is...
I don't care. The best one is the therapy one, and you say, okay. And in the end, my conclusion is you need both.
Yes.
Now, whether your age, your willingness to go or not for chemotherapy, the result have to be modulated. But basically, it's a super important trial.
And it highlights the importance for designing and running these trials.
As for the PARP inhibitor, I'm biased, because I'm kind of a ayatollah of evidence, and we need the OS to see whether it's practice changing. If it is, we will. If not,
come and go.
Yeah, we'll see.
But either way, I think the future is bright. We got that out of
Surely.
that session. And thank you very much for your time and your
You're welcome.
insights.
Thank you
and I
so
look
much.
forward to having your presence for the rest of the week.
Thank you.